In discussing fluid therapy, I will be relying on your knowledge of your hematology topic in Fissile 1. Alright, so let's review on the body, the water compartments or fluid compartments of the body. Right, so these are cells, the cells that you see there. Alright, the nucleus would be the gray one, surrounded by the interstitial fluid and the blood vessels running through the cell, supplying it with oxygen and ATP would be the intravascular compartment. And anything outside the blood vessels would be the extravascular fluid or compartment. And the extravascular compartment is comprised of two different fluids. One would be the fluid inside the cell, which is called the intracellular fluid, and the fluid outside the cell but not in the blood vessels would be interstitial fluid. So understanding this, the mechanics of these fluid compartments as to how they shift and why they shift is very important in understanding this lesson. Right? Now, why is it important for us to discuss the fluid compartments? Majority of the fluid in our body is located intracellularly where they are needed. They maintain cellular integrity, the cell shape. They also would be a significant factor in cellular functions. Right? So in an adult, it's usually 67% intracellularly, 33% would be extracellular fluid, and that 33% is divided into the interstitial fluid, which is just 75%, and the intravascular fluid, which is the blood, is 25% of that 1/3 of the body fluid. All right? So fluid administration is very important for certain cases wherein we need to maintain or restore normal cellular function. Right? Why do we give fluids? General roles of fluids, fluid therapy. We have to replace any fluid loss. Right? And this could happen through a variety of pathologies that affect an animal species. In administering fluids, we also have the goal of correcting electrolyte imbalances. We have to promote kidney diuresis, and of course, in case that there's fluid loss, we have to maintain tissue and organ perfusion. Because kung walang dugo, kung kulang yung tubig na dumadaan dun sa mga blood vessels, then there will be a problem with how perfused or how efficient oxygen delivery is to the tissues or the peripheral tissues. All right. So there are a lot of fluids available, and they would have their own indications as to why we give them. Right. General categories of fluids would be crystalloids versus colloids. Crystalloids are water-based solutions containing osmotically active electrolytes, right? And it will also include some non-electrolytes but are permeable to the capillary membrane, right? And there are three types of crystalloid fluids. You would have isotonic, hypotonic, and hypertonic. Again, this is just a review of your fish oil. All right, and the tonicity, how you identify the tonicity of the fluid would be comparing it with the tonicity of the plasma. Right, so the other category of fluids would be colloids. These are crystalloid-based solutions, but instead of it entering the capillary, the molecules in colloids are retained in the IV fluid compartment. So instead of them going into the cells or the interstitium, they would pull water from the extracellular compartment to the intravascular compartment. All right, and there are two kinds of colloids, natural and synthetic. Let us discuss crystalloid fluids first. There is a variety of crystalloid fluids available, not just for veterinary use but also for human medical use. All right, and the difference of these fluids would rely on their contents, on their ingredients. All right, but I would pull your focus instead to the osmolality of the different crystalloid fluids. When we say osmolality, this is just the concentration of solutes in a solvent. The main difference between osmolality and osmolarity is the denominator. Osmolality, it's in liters, osmolarity is in kilo, right? So since we are talking about biological fluids, osmolality and osmolarity are basically interchangeable when talking about biological fluids. Of course, when you talk to a chem major, they would be very different for them. But for us, we're talking about blood, we're talking about plasma, we're going to use osmolality. And why is it important for us to know the osmolality of the different fluids? Bakit hindi na lang tayo basta magbigay ng fluids sa pasyente kasi kailangan niya ng fluids? Why are these important? Right? And this is a very common mistake to make as a veterinarian, to not pay attention to these characteristics of the fluids, and knowing the different composition of the different solutions would actually make your judgment as to what fluid to use be more sound and be more specific as to what your patient needs, right? And what is the relationship of that osmolality of the fluids? There is a normal physiologic osmolality, and this varies between animal species, but the range is 280 to 310 milliosmoles per liter, right? And the body, our bodies, have this mechanism to maintain that osmolality, right? To maintain the balance of electrolytes, to maintain the balance of cations and anions. We call that homeostasis, right? That is just the way our body does it. So anything that is in excess, anything that is deficient, our body would have to compensate for that imbalance, right? So what is the common fluid that is used widely, right? That is saline. 0.9% saline solution, or normal saline, as some veterinarians would prefer to call it. And why is this why is this commonly used? Number one, it's cheap. It's the cheapest of all. It's cheaper than lactated ringers, even if it's just a difference of 10 pesos to 20 pesos per liter. You know, if you go to Bang Bang, you'll know this when you return to class and you do the surgical procedures, and you have to buy things. Bang Bang is the way to go, and you will be able to see saline is the cheapest because it only contains water and salt. And for large animals, this can be reconstituted using your kitchen things. You can make 0.9% sodium chloride. But what is the problem with this? All right. Oh, I think I will be focusing on the saline later. But look at the osmolality of saline. It's 308. Yes, within the normal physiologic osmolality, but it is on the upper border. As compared So lactated ringers and normal sol, which has 274 osmolality, 295 osmolality, which is just within the, it is basically safely in the middle of that physiologic osmolality. So when I'm asked repeatedly, Doc, if you only have a choice of one fluid being in stock in your clinic, what is your option for that? I always go for Normosol. A Normosol R or Plasmalite, right? Or Plasmalite. They have the same pH, they have the same composition, basically. It's just a difference in buffer source, right? It is not commonly used in the Philippines, and I wonder why. But when I got to talking to a lot of veterinarians practicing in different countries, Australia, US, Europe, Hong Kong, Japan, right? They always use Normosol. Yes, it is more expensive than lactated and saline, but it is the way to go for them. All right, we'll talk more about why it's that choice. But the next fluid would be Hartmann's. Lactated ringer solution is also called Hartmann's. Especially if you do not have access to Normosol and Plasmalite, I would always go for LRS as compared to saline, because it is these are what we call balanced electrolyte solutions, or BES. All right, lactated and Normosol. Let's go to detail for them. This is a table of the normal serum concentration of the plasma concentration of electrolytes, sodium, potassium, calcium, and all of it. So there is a normal level of these electrolytes in our body. So you have to think, how are you going to change these electrolyte imbalances when you give it fluids, and how much are you changing it? If there's a deficiency in potassium or in calcium and sodium, how are you going to supply that but not cause imbalances in the other electrolytes? This is why fluid therapy is such a beautiful dance, right? And makes it so complicated to teach and study as well, because it all depends on what your patient is doing, how your patient is, the current health status of your patient, and what electrolytes is it currently deficient or in excess of. So let's go into the different types of crystalloid fluids. Isotonic crystalloids would have the same same sodium concentration as the extracellular fluid, right, or the plasma. So that means this fluid, since they have the same tonicity, will be distributed in the ECF only, right? It could go into the interstitium. They will not be accepted by the cells, and they could go from the interstitium back to the intravascular space. So this is why they are called ECF replacement fluids, right? So mainly for perfusion support and volume replacement. Okay, if you need something that will be inside to restore volume of the blood vessel, this is the way to go. This supports dehydration of some patients wherein the interstitium is lacking fluid. That's what you need, right? So saline, lactated ringers, or in some countries it's called Hartmann's, and Plasmalite A and Normosol. All right, okay, so let's go at it one by one. I'm not gonna focus more on Plasmalite because we don't have it here in the Philippines, so I'm gonna focus more into saline and LRS. All right, so saline. Okay, when you look at the ingredients, right, sodium will be 154 milliequivalent per liter. Chloride will be the same thing because it's sodium chloride. pH, a little bit acidic, and this is where the problem lies, right? Remember, the normal physiologic osmolality is 280 to 310, right? And the total osmolality of a saline is 308, okay? Now, the normal sodium in the body of an animal is 140. Okay, it's just my threshold. It's 140. So if you're giving it 154 milliequivalent per liter, the extra 14, 154 minus 140, is negligible. It can be removed by the body in a lot of ways that will not be detrimental to the animal, right? Sweat, urine, a lot of things, right? The problem with saline is the chloride content. The normal chloride concentration in the body is only 100, okay? That's the only level that you want to maintain chloride in. And sodium, 0.9% saline is giving it 154, an excess of 54 milliequivalent per liter. And the way that you can remove chloride in a system is not as easy as sodium. Okay, you don't have like chloride transporters. When you want to move chloride from one compartment of the body, you have to get chloride back, right? It's an exchange transporter. So saan napupunta yung burden ng pag-excrete ng extra chloride? It goes to the burden goes to the kidneys, right? This is why prolonged use of saline sometimes leads to renal insufficiencies, because the the blood vessels in the glomerulus tend to overwork just to remove that chloride, which you think, this is cheap. Any excess would just be excreted. Yes, it will, but at the expense of your kidneys, right? This is why I don't commonly go for saline as my first bag of choice. When you choose your first bag kasi in the clinic, right? When a patient comes into your clinic, you identify that it needs fluids, it needs to be stabilized, and you have to choose your first bag of fluids with a limited data on the clinical pathology. You do not have blood test results yet. You do not have any electrolyte results yet. So you are deciding it quite blind, and sometimes a lot of vets would go for saline because it's what's there and it's what's commonly used. The thing is, what if this patient, might be in more harm than good if we give it saline as compared to other balanced electrolyte solutions, right? That's the main problem with saline. But again, it is still a good fluid as long as it's not used very prolonged duration. And also, if you are treating a condition wherein these electrolytes are of deficient status, right? For example, prolonged diarrhea could decrease the sodium concentration. It will lead to hyponatremia, and they would benefit from saline. Severe hypochloremic metabolic alkalosis commonly happens in patients with who are vomiting. Okay, that causes low chloride ions in the body, lower than 100. And why do they have lower chloride content when they are vomiting? Because they are actively excreting HCl or hydrochloric acid, and when you do not supplement that, when you do not replace it, then there will be a low chloride content, and they would benefit from saline. Okay, ruptured bladder could also lead to low sodium. And when you want to maintain IV catheter integrity, kapag naglagay ka lang ng swero sa pasyente, pero catheter lang siya, hindi siya nakakonekta sa fluids, you would expect that the blood there, the catheter would develop a clot, and that will be blocked. So for you to maintain use of that catheter, you need to flush it with saline or with heparin saline regularly, maybe around 2 to 3 times a day, right? Especially if it's not connected to fluids. All right. With lactated ringer solution though, right? Look at this contents. Sodium 130, potassium 4, calcium 3, chloride is 109, close to 100 as compared to saline, which it has 154 milliequivalent per liter chloride. Lactate here is the buffer, which is 28. So when you add the cation ions on the left and the anions on the right, it's a balance of osmolarity of 274, which is near or within that physiological osmolarity, right? So these are also what we call alkalinizing fluids, along with normal salt and plasmalite. The thing is, the thing that makes this quite used with caution is that it has calcium content, which causes some drugs to precipitate. If you are in a clinic right now, or you have experience in a clinic, or you're volunteering, I was volunteering as well when I was a student. When kapag in-inject mo yung drug sa IV line na may lactate, na lactated ringers yung nakalagay na fluid, for some drugs, you could actually see it crystallize once you are infusing it. Para siya nagiging powdery pagpasok, and that's not good. Okay, that's not good, right? Your drug is basically wasted, right? So you have to. This is why some people would not want to use lactated ringers because of that complication. All right. So when do we use this? Again, this is still a very good. This is my first bag of choice. You could use it for temporary blood loss to replace the blood that was lost. Temporary blood pressure support in terms of shock, which we will be discussing in detail later. Metabolic acidosis, or there is low pH in the blood. Again, this is an alkalinizing fluid, so it helps. 6.5, pretty close. And it can be of daily fluid maintenance, right? I said lactate is a buffer, right? And the thing that you always hear about lactated ringers is you do not use it for patients with hepatic insufficiency, right? Because of the lactate. But how so? Okay? I always like the why and the hows. Okay? If you're gonna ask it, I'm gonna answer it anyway. Right? Lactate here acts as a buffer, right? Whenever you see it, acetate, gluconate, lactate, these are buffers. And the usual buffer that we use is bicarbonate, right? That's the usual buffer because you have to maintain the pH of this solution, right? That's why you have a buffer for that. Now, why do we use lactate? Bicarb, which is the common buffer that you use, is not stable. And when you subject it to sterilization, because these fluids need to be sterilized, the bicarb that is added to the fluids dissociates into hydrogen ions and CO2, right? But the buffers, lactate, acetate, gluconate, are stable during sterilization. And these three buffers, lactate, acetate, gluconate, are metabolized by the liver, and in there they are converted to bicarb. Okay, so it requires a reasonable liver function to work well. Right? So let's go to hypotonic crystalloids. These are fluids with a lower sodium concentration as compared to the ECF. So with it requires your basic knowledge of chemistry, right? Diffusion, osmosis, and such, right? If the fluid in the blood vessel has a lower osmolarity as compared to the ones inside the cell, where would the fluid go to maintain homeostasis, to maintain that balancing act? Then the fluid will go inside the cell because there is more solute in there, right? This is why hypotonic crystalloids are called whole body replacement fluids, right? Because the lower osmolality makes it drawn into the cells. So they can be very good for correction of electrolyte imbalances, right? And the most common hypotonic crystalloids used would be half strength or 0.45% saline solution. You see it's half of the 0.9, so sometimes it's called half strength, and 5% dextrose in water, right? So these are just some of those. All right, I'm just going to discuss 5% dextrose in water here because it has more application, and again, I haven't found a half strength fluid in the Philippines. I mean, update me if you have found this. Good job, because it's very good to handle kidney insufficiency problems. All right, 5% dextrose in water. Why do we give dextrose in the fluids? Right, dextrose is in the form of D-glucose monohydrate in this concentration, 50 grams per liter of water. This is the osmolarity and the pH. When do we use it? Okay, this is the best way to give pure water into the body. Right? Yes, it will help with hypoglycemia as well, but dextrose is readily and efficiently used up by the cells as soon as it enters the blood vessel. So basically what is left is the water. All right, so that water can go into the cell in cases wherein there is intracellular dehydration. Hyperkalemia can also be addressed by 5% dextrose in water. I will ask you why is that. I would want you to research as to why or how hyperkalemia or increased potassium concentration in the blood can benefit from dextrose administration. All right. So again, this can also be used to add glucose to LRS or saline at this rate. All right. So hypertonic crystalloids. So basically the reverse of hypotonic. The fluid in this fluid has a higher sodium concentration as the ECF. So kapag mas mataas yung osmolarity sa blood vessel, where would the water go? So the fluid in the cells, the water in the cells, will be drawn out into the ECF to balance things out, right? So the hypertonic crystalloids would be retained within the blood vessel and it draws in water. So why is this good? Why would you want to get water from the cell? This is good for when you need the blood volume to be increased immediately, and when your patient cannot tolerate large volumes of fluid boluses, right? When your patient is hemorrhaging or actively hemorrhaging in surgery, right? So you want to replace that blood. Okay. However, your patient has for example, a heart problem, and that could predispose that patient to fluid overhydration of fluid. All right. Then you cannot give too much of the saline or the LRS. What you could give is a hypertonic crystalloid. So instead of putting so much fluid in the body, you're utilizing the fluid already in the body to shift its location from inside the cells and go into the blood vessels to restore circulation. Of course, after you give hypertonic crystalloids, you need to follow it up with isotonic crystalloids para yung kinuha mo sa cell ay ma-replace. Right? So this is usually used for emergency purposes. Those suffering from for emergency purposes wherein you need blood volume rescue basically, and if there's too much water inside the cells, like there's edema, there's effusions in the interstitium, that actually helps remove the extra fluid in the extravascular compartment, right? Hypertonic saline is a classic example of a hypertonic crystalloid. Just look at the amount of sodium and chloride in them, 1232, balance of an osmolarity of around 8 to 10 times the normal physiologic osmolality. So when do we use it? For rapid but transient expansion of intravascular volume. The duration of effect is usually just 30 minutes. In horses, it's usually 45 minutes, and there's a dose for it, right? There's a max of 5 ml per kg, and in some literatures, you actually see this increase to 6 ml per kg, but we'll just go with 5, right? And this is one-time use, right? You can only administer it once to restore blood volume to get that fluid from the cells, and then you have to go with the isotonic crystalloids. All right. So next, colloids. Right. These are large molecular weight substances that do not cross the capillary membrane. Right. They are restricted in the blood vessels. So these are used for treatment of shock and severe hypoproteinemia when walang protein sa plasma ng animal, right? You have the natural colloids, which is the whole blood, packed red blood cells, and the fresh frozen plasma. This is discussed in part 3 of module 3, And of course, we have the synthetic colloids. Whenever we don't have the natural colloids, these synthetic colloids work the same way, even though they are synthetically manufactured. Right? The one synthetic colloid that we've always used is head starch. This is hydroxyethyl starch. This is made from high molecular weight molecules of polymers of amylopectin, which causes this colloidal osmotic effect. Okay, basically it's also attracting the water from the intracellular compartment so that it will go into the intravascular compartment. That leads to volume expansion. Okay, it's usually prepared with in this concentration 6% solution with saline or LRS, depends on the manufacturer. And when do you use it? You increase the plasma colloid oncodic pressure in times of shock, hemorrhagic. We'll discuss shock next. So that causes increase in blood volume, which improves cardiac output, which improves blood pressure. Cases of hypoproteinemia, when there are coagulopathies, severe inflammatory conditions, disseminated intravascular coagulations, and it has a longer effect than hypertonic saline. It has an effect of average of 24 to 36 hours of a dose of 4 ml per kg over 15 minutes. Right? Again, literature would be quite interchangeable with that. Right? You'll see some literature which says it's 5 ml per kg, some would be 4 ml per kg. It just depends on the animal species. All right? Now, how do we give these fluids? Right? What are the routes of fluid therapy?